طبيب من المنصورة، يعني قلبا وقالبا، بكالوريوس وماجستير ودكتوراه من جامعة المنصورة، والآن لكتشرر في أغلب الجامعات الأمريكية، رئيس اليونت اوف نيوتريشن ستدي في جوزلين سنتر. والدكتور أسامة استطيع أقول عنه أنه الطبيب الشامل إخلاقا وسياسة وعلما، والآن أسس فرع لجوزلين في مصر، إن شاء الله يرى النور قريبا. تفضل أسامة. الدكتور أسامة لو تكلمنا عنه سيأخذ الحديث يعني ساعة أو أكثر من ساعة. كل اليمنيين مشتاقين لسماع الدكتور أسامة حمدي، والدكتور أسامة حمدي يا دكتور أحمد سيجيب عليك أن اللايف ستايل is the main أو proper management for type 2 diabetes. تفضل دكتور. His talk will be about remission of diabetes type 2.
السلام عليكم ورحمة الله وبركاته. ألف شكر دكتور زايد، يعني أنت دايما مجامل ولسانك أروع ما يكون، فأنا ما استحقش كل اللي أنت بتقوله، لكن أحب أن أنا أحييكم جميعا في اليمن الحبيبة العزيزة الغالية لقلبي جدا، وأنا حريص يعني دايما أن أنا أكون معاكم كل عام ونتكلم في موضوع جديد وهام. واعتقد موضوع النهارده هيهم الجميع بشكل كبير جدا. احنا قطعنا شوط كبير في الولايات المتحدة في هذا المشروع، واتمنى ان يكون اليمن طبعا احد الدول الرائدة في مشروع الدايابيتس ريميشن. عايز اقول ان يمكن من حوالي 10 سنين من النهارده we were the first to say that diabetes can have a remission, and at that time it was astonishing. What we had seen was seen in one of our studies on weight management in people with diabetes, and we've been doing this weight management program since 2005. And in 2015, we started to do analysis for those people who did weight management for 5 years and then for 10 years. And we were astonished. We were shocked. We found that 21% of them get remission from diabetes. Some of them get A1C lower than 6.5. Few were able even to get A1C lower than 5.7 and stopped all their medication or just being on one tablet of metformin, maybe 500 milligrams. So we started to go back and look who are those people who got remission from diabetes. And what we found is 3 major criteria that is common among all those people who have who had diabetes management during our weight management programs called Y-Weight program. And the first criteria is that they have diabetes less than 5 years. The second criteria is that their A1C at the beginning of the weight management was less than 8%. And then they are managed on 2 medications, but not insulin. Whatever those medications, injectable or oral, at maximum dose or not, but they are not on insulin. There is some exception, but it is rare. But these are the 3 criteria that we found that everyone who entered the program with this criteria were able to get remission from diabetes. So this article opened the eye for the concept that diabetes remission can occur in clinical practice. So later on, there is a group that met together from thought leaders to define what is meant by diabetes remission, because we don't need everyone to come with his or her definition of diabetes remission. And we had seen this a lot in people who are doing bariatric surgery. They sometimes define remission with A1C lower than 7. Sometimes they define it lower than 6.5 on medications. So we have to come to a consensus on what is the diabetes remission means. And the consensus was that if you were able to get A1C to lower than 6.5, or the estimated A1C lower than 6.5, no medication after intervention, and remain on remission for 3 months. No medication for 3 months after the intervention, and still the A1C lower than 6.5. Of course, this is a short-term remission, but you can go as long as you can. You can say diabetes remission for 6 months, diabetes remission for a year, or diabetes remission forever. It is similar to the concept of cancer remission. It doesn't mean there is a cure. It doesn't mean it had been resolved, but it means the disease is in remission. And of course, if the factors that led to the disease to start with, like obesity or aging or any other problem, or certain medications, maybe those people will develop diabetes again. But the whole idea is that you can put the disease in remission and no medication for a period of time. And people start to ask, what is the pathogenesis for remission? If this is possible or not. So let me go back to a study. It was very, very popular study that I did almost 23 or 22 years ago. And we found that when people lose around 7% of their body weight, their insulin sensitivity improves by 57%. If we assume that type 2 diabetes problem is mainly insulin resistance that lead later to beta cell dysfunction, then you can improve insulin sensitivity by that much, by just a 7% weight loss. I remember when we did this study, I was whispering to my colleagues at Joslin, and I said, you know, that means the disease is not a chronic disease. That means that the disease can be reversed. But that concept was not there 22 years ago. Until bariatric surgery started to show that actually when people lose weight, many of them can get remission from diabetes. But people who didn't believe in this study at the time repeated the study using the glycemic clamp technique. In this study, we used the frequent sample IVGT, which is one of the gold standard techniques to measure insulin sensitivity. They used the glycemic clamp, and they found 80% improvement in insulin sensitivity and 90%. And from that time came the whole concept that if you help people with diabetes, especially in the very early stage, to lose weight, you may get remission. But people said, okay, from a pathological point of view, how this remission can occur. So let me explain a scenario that most of us know very well, that when people start to gain weight, they start to be insulin resistant, and they remain insulin resistant for the rest of their life. Of course, the beta cells are trying to compensate and secrete more insulin. And then over time, the beta cells start to dysfunction more and more, and then it starts to fail. So this beta cell dysfunction is over time. It is not just immediate, but it is over time. And you can see here around 5 to 7 years where there is controllable hyperglycemia. You can control it in a very nice way because those people are still making enough insulin. And then later on, there is period of uncontrolled hyperglycemia as beta cell dysfunction progress. But we didn't ask ourselves, if we improve insulin sensitivity to the maximum, I return that person back to be insulin sensitive, whether by medication or by weight loss. Medication is not enough to do that job. But weight loss can do that job. Will we able to return the beta cell back and induce diabetes remission? This is a question that we had been asking for years. But pathologically, it became obvious that beta cells don't die, don't fail. What happens is that once the blood glucose start to go significantly up, as you can see here, beta cells start to revert or de-differentiate itself. So de-differentiation of beta cell reverted to be progenitor like cells or progenitor cells, and then start to be modified to be alpha cells. So beta cells in the presence of hyperglycemia become alpha cells, progenitor cells in alpha cells, resulting in hyperglucagonemia, and people have hyperglycemia again. But interestingly, once you start to improve this glucose toxicity and improve blood glucose level, the beta cells start to revive back, and then if you bring the blood glucose level to normal range, then the beta cells are back. So alpha cells become progenitor cells and then take the fate of beta cell, which means that it is a continuous transformation between beta cells and alpha cells. Beta cells secreting insulin, alpha cells secreting glucagon. So the whole idea is that how you can return back the beta cell. But this means it is a reversible scenario. It is not a permanent scenario that will continue to be like any chronic disease. So the question at that time is, what intervention can induce remission? If there is way that we can induce remission, especially in those people in early diabetes. We know for years that weight reduction is the best way to do it, but it is not just put people on hypocaloric diet. This is more complicated than what you may think. You need to know how much weight loss that you need. You need to know what is dietary intervention that you will use. Dietary composition, caloric level, meal replacement, whatever you will use, you need to define it very, very well. You need to know what type of exercise, what duration of exercise, what frequency of exercise, what to do from behavior point of view, and also what to do with medications. Because many medications are actually speeding up that process. If you put people on insulin, put people on sulfonylureas, you are secreting more insulin. Insulin is a growth hormone, make people gain more weight. It became like closed loop that people will enter in and don't grant. But the most important is that how you can maintain this for very long time. That's why people were frustrated that we can find a lifestyle intervention to do that. We spent around $16 million over years to define what is needed for weight management to get a very good weight management. But before we go through this, we have to define if what we need is 7% weight loss or what we need less. In reality, 3% weight loss can have some metabolic impact. 5% weight loss will be even better. 7% definitely is ideal. But studies have started to show that you need around 10 to 15% weight loss in comparison to 5% weight loss. And if you will be able to do that, the hazard ratio, as you can see, is significantly high. And it became obvious that every kilogram weight loss increased the odds for diabetes remission by 32%. So as high as you can go with weight loss, the odds for diabetes remission at 1 year will be higher. So we, in 2005, we created a program, a multidisciplinary program based on that amount of research. That include exercise model that basically trying to keep muscle mass up all the way from day one. Nutrition intervention that also help to keep muscle mass up, but with hypocaloric and higher protein and lower carbohydrates, with cognitive behavior modification and education. And we were astonished to see that after 5 years of intervention, and this was published in the British Medical Journal, that we were able to keep weight loss around 6.4%. And as you can see, more than 50% of people, especially who lost more than 7% in the first year, were able to maintain around 9%. Actually, this is around 53% of the total. The other 47%, they gained some weight, but still their weight is down. But if you take the entire group, you will find 6.4% weight loss. And we said, okay, let us continue to observe those people for another 5 years. And interestingly, at 10 years, we noticed that it's still the same. People are still maintaining 7% weight loss after 10 years of this very sophisticated multidisciplinary intervention. So they did it for 12 weeks, but they are still maintaining the weight loss for 10 years. And just a few weeks ago, we were able to publish even 15 years. And at 15 years, they are still maintaining 7.6% weight loss. And those people who lost initially more than 7% will be able to maintain 11% weight loss, which is now telling us that actually lifestyle intervention, if it is done properly, will maintain weight loss for up to 15 years. So all that frustration that people will lose weight, they will gain weight back, put them on GLP-1, put them on whatever medication. We found that actually proper lifestyle intervention can work in reality very well and induce a quality weight loss, not a quantity weight loss. Quantity weight loss means there is big loss in muscle mass. You lose weight, but like a GLP-1, 40% of the weight loss is muscle mass. But in this scenario, only 9 to 11% of the weight loss is muscle mass, which is entirely different. And this is the data that we started to see remission, which I told you at the beginning. Also, people who did very low calorie diet. Very low calorie diet means 800 to 1,000 calorie diet. And this study is actually comparing surgery, Roland-Y, gastric bypass surgery, before and after, and also very low calorie diet before and after. And they measured the insulin sensitivity and acute insulin response, which is early insulin secretion, which is indicator, very good indicator of beta cell function. And as you can see, it is very interesting whether you do gastric bypass surgery or you give people very low calorie diet, the improvement in insulin sensitivity and the improvement in beta cell is exactly the same. So if you need to do bariatric surgery, you can do also very low calorie diet and it can do the job. So from that, a group in Scotland started to take people and put them on a very low calorie diet by total meal replacement. So they don't eat, they give them shake with 800 to 1,000 calories. And they call it direct study. And what they found that people who lost 15 kilogram have 86% remission. People who lost between 10 and 15 kilogram, they have 57% remission. Of course, this is a very tough method to do to induce remission because people will not replace the entire food by just shake. And for how long? People cannot do it can do it for short period, but they cannot do it for very long time. But the study was done for a whole year. Then the third method, so we have multidisciplinary weight management, we have very low calorie diet. The others is to cut carbohydrates. If you cut carbohydrates way down, and there is a meta-analysis of 23 randomized clinical trial, and as you can see, most of them showed the odds for diabetes remission is significantly high. So here is a meta-analysis of the 23 study, including more than 1,300 patients with type 2 diabetes, and they put them either on low carbohydrate diet less than 130 gram, or very low carbohydrate diet more than less than 50 gram, very, very low carbohydrates. And then they started to see them in 6 months and in 12 months. And as you can see, in 6 months, there is a very good odds for remission. But unfortunately, with this very tough diet, they were not able to maintain it for 12 months. As you can see, it crossed the line here. So it was very efficient at the beginning, but not at the end. And people were on no medication at the beginning, but at the end, they were not. Of course, the A1C improved significantly at the beginning, but also was not be able to be maintained. And then Jocelyn, 3 years ago, came with another model, and this is a very interesting model. It's called the DROP. DROP means Diabetes Remission Outcome Program. Diabetes Remission Outcome Program. And this is a flagship of our programs now for diabetes remission. And what we were aiming to achieve is that to find a program that can double, that physician can do in their clinical practice in very easy way, because all other previous program, as I mentioned, are very tough. Bariatric surgery, very low calorie liquid diet, they are extreme and they cannot be endured and unsuccessful in maintaining remission for long time. And they are, this is a major drawback, they are accompanied with significant loss in muscle mass and can even put patients at the risk of malnutrition. So we know those are good intervention, but the drawbacks and the complications and the side effects are significantly high, and people cannot maintain it. So the risk-benefit ratio is an issue. So we designed this diabetes remission outcome program, and the idea is to combine some of what we learned over years from all this concept of diabetes remission, and to do it for the right people from the beginning. So this is a novel, this is a doable program. Any one of you can do it tomorrow in their clinical practice if they would like to do. And it has a long-lasting effect, and I will share that with you. But the most interesting is that from day one of the program, people stop all their medication. So no medication from day one of the program. And let me explain how it is done. So first, based on the criteria that we got from Y-Weight program, we only include people who have the 3 criteria. Newly diagnosed with diabetes within 5 years, A1C at the beginning less than 8%, on 2 medications up to the maximum dose, but not insulin. So if you have people with this criteria, they are eligible to be in the DROP program. So DROP program is 2 phases. One phase is 12-week phase, and then maintenance phase after that. So this is intervention phase, 12 weeks, maintenance phase, 9 months. So the whole is 1 year. So the idea of the program, number one, during the intervention phase, is to put people in a very low calorie diet, but not a liquid diet, just a very low calorie diet. During the maintenance phase, you can go back into 1,500, 1,800 calorie diet. So 800 for women, 1,000 for men in the intervention phase, 1,500 for women, 1,800 for men in the maintenance phase. But the macronutrients are very, very important. You need to keep the carbohydrates lower than 40% and increase protein. They need 1 to 1.5 gram per kilogram protein. Protein will not calculated as ratio, it's calculated as gram per kilogram, because you need to give people more protein, more strength exercise to maintain muscle mass. But one of the drawbacks is a loss in muscle mass. With medication that cause weight loss, with bariatric surgery, with very low calorie diet. So in this scenario, you need to oppose all of this and keep muscle mass up. And the only way to keep muscle mass up is to give them higher protein especially animal protein, and more strength exercise. And then the fat from healthy sources, we don't care as long as it is MUFA, BUFA, or omega-3. So olive oil, canola oil, other types of oil, fish oil, nuts, all this are fine. And then the novel part that we used in this program is intermittent fasting. And I bet, we're coming to Ramadan. Ramadan is a very, very good example of what we call it time-restricted eating. So we give time-restricted eating. So people eat their supper or dinner fasting for 16 hours, similar to Ramadan fasting. And then they get a shake and diabetes specific formula to break the fast on 200 calorie diet. If the shake is not available, people can make their shake at home, some protein, some fruits, and just blend it. And then you get 200 calorie in that scenario. So you break the fast on higher protein, and then you eat a dinner, 600 to 800 calories. At the beginning, we thought that this will be very difficult, but when we start to tell people that you will be able to get remission from diabetes, they were able to tolerate that scenario. And then the fast again. So people are doing it similar to Ramadan. You fast, you take the shake. Of course, you can drink water, tea, coffee, whatever, as long as they don't have sugar. And then breakfast, and then another dinner, and it's very simple. And for the dinner, we give them the plate method that you just put the protein, you put the vegetables and the salad and some little carbohydrates, and they can have one piece of fruit. So it is not that difficult and very simple. But the most interesting and most important is that we put all of them on continuous glucose monitor and started to teach people about time and range. And we asked them that we need time and range to be always above 70% in the first 12 weeks. If it goes lower than 70%, maybe we can put them back on one of the medications, metformin or similar. But so far, after 2.5 years, no single person required to be on any medication during that period. So in the intervention phase, we stopped all medication, and we told them that we reintroduce the medication if the time and range go lower than 70% in the first 2 weeks. But in the maintenance phase, we raised the bar high. We need them to be above 85% all the time. And we told them, if you go lower than 85% time and range, do 1 or 2 weeks similar to the intervention. So the program now has a self-correction piece. So if your blood glucose starts to go up again, you can go and do very low calorie diet, time restricted eating for 1 week, 2 weeks. You correct it, and then you continue again. And then we measured all the measurements that we usually do: A1C, lipid profile, urinary macroalbumin, creatinine, lipid profile, liver enzymes, calculated GFR. You can do also inflammatory marker like high sensitivity CRP. So let me review it again. Discontinuation during the intervention phase, discontinuation of all medication at the start of the program, time-restricted fasting for 16 hours, very low calorie diet, 800 to 1,000, natural food, and the diabetes specific formula. And I insist on natural food because people, they may fast and eat food better than just to be on a shake or stuff. Even if you don't have a shake, you can make it, or maybe you can just give them 200 calorie to break the fast, and then 600 to 800 later on. But the most important is you need higher protein and you need strength exercise. Very, very important that they will do 20 to 30 minutes every day strength exercise. And especially exercising big muscles like thigh muscles, quadriceps, hamstring, also shoulder muscles. And the simplest way is squatting. If they squat and up, that can be a very good exercise. They can use some weights, some stretch band. They can use a stationary bike if they have elliptical against resistance. Anything that let the thigh muscle to contract. They have to feel the contraction in their thigh muscle. Very, very simple. It doesn't have to be in a gym. It doesn't have to be outside. They can do it at home. But higher protein and strength exercises are very vital in that scenario. And then behavior modification, if you have a model for that, you can do, and use CGM for the entire duration of the program. Then in the maintenance phase, people are going back and eat 1,500 to 1,800 calorie diet. Women 15, men 18 is sufficient calories for them for the day. But be careful to keep the carbohydrates lower than 40% and keep the protein up. And try to aim for timer range more than 85%. That's very, very important. If it goes lower than 85, then they have to do 1 week or couple of weeks, as I mentioned. So let us show you some of the data that we have. People started with 1.6 medication at the beginning in average. From day one, they are off medication, and by the end of the program, there is no medications. Timer range was 91 on the medications. Now is 97 on the without the medication, which is very interesting. And they lost around 8% of their body weight, enough to induce that amount of remission. But you have to remember, those people maintained the muscle mass. So they lost weight, 8% of their body weight, but most of the weight loss is fat mass. And as you can see, A1C, those are Joslin patients controlled on medication. 6.4 at the beginning, they are on 2 medications, doing very well to start, but now they are off medication from day one. And you can see the A1C continue to be low, 6.1 for the 12 weeks. And as you can see, this is a real CGM for those patients, and you can see 99% in range, 99% in range, 96% in range, 97% in range, 100% in range. So they are actually getting that remission. One of the most important for us is how much they lost from the muscle mass and fat mass. And interestingly, most of the loss, as you can see, in fat mass, from 97 pounds of fat mass down to 83% of fat mass. And we calculated the muscle mass to the fat mass ratio, and it went up. So that's what you need. You need them to have more muscles by the end of the program, even with the very low calorie diet and time restricted eating. Then we started to follow those people by this technique that if they go up more than 85, lower than 85% time range, they repeat 1 week or 2 weeks. And interestingly, up till now, we have 2.5 years of follow-up of this group of people, and still A1C lower than 6.5 on no medication. So we're able to maintain remission. So this is a long-term remission now. We are planning to continue to follow them for 3 years, 4 years, 5 years, and so on. What's very important, their quality of life improved significantly, 100% improvement, 100% of participants reported improvement in quality of life. I am back again. I don't have diabetes now. I'm no medication. I'm feeling much better. This is a group that did the program at the beginning. This is the first group, and the team at Joslin that worked with them. So in conclusion, DROP is a novel and doable protocol to induce diabetes remission and improve quality of life among selected patients. This is not for anyone. This is for only people with early type 2 diabetes, with A1C lower than 8%, with 2 medications, and are diagnosed within 5 years. You may try 6 years, you may try 7 years, but the best results in less than 5 years. We are making a larger cohort now in the US, And several countries across the globe, there are like 6 or 7 countries are doing their cohorts as well right now on the DROP program. And I am hoping that this will be among the guidelines of the American Diabetes Association when all those cohorts are published as the model to start management of diabetes with that. And if we keep refining this model in the future, maybe we will not need any medication in the future for the newly diagnosed patient with diabetes. So it is a step to the future until we have a diabetes-free zone. So take to practice message from my presentation. Diabetes remission can be achieved in real-world clinical practice. You had seen the model of the DROP program. Diabetes remission is more likely to occur in patients with shorter diabetes duration and not in insulin. Time-restricted eating in combination with very low-calorie diet that include diabetes-specific formula. If you can, if you don't, you can make your formula. And structured meal plan are effective tool for diabetes remission. And when I say structured meal plan, we give them menus because we will need to know what a 600, 800 calorie meal will be, and we give them 10, 15 of those menus. Very simple, it's a plate meal. Higher protein intake and strength exercise are essential, very essential in minimizing muscle mass, and especially if they do strength exercise after they take the protein. Right now, we have a protein shake, 60 gram protein in the shake. We advise them to take the shake and do 10, 15, 20 minutes of strength exercise, and then eat dinner later on. With this, I would like to thank you and welcome to the brighter future, maybe I hope without diabetes at one time. With this, I would like to thank you so much for listening.
دكتور أسامة شكرا كثيرا for this
I cannot
nice.
hear you because I cannot hear you. You are muted.
دكتور
Yeah, that's fine now.
مسك الختام لنشاط اليوم وأجابت على كثير من الأسئلة زملاء من الصباح يسألون عنها. يعني they want to answer the questions how we make the quality of life is applicable and acceptable and make control for weight and for diabetes. يعني المحاضرة أجابت عن كثير من الأسئلة والفلور is open for questions. The first one, my professor Dr. Abdul Karim Hajar, cardiologist, were the most of the questions. The hand rise are cardiologists. You are welcome.
Thank you very much, Dr. Osama, for this very nice lecture. Actually, in your patients, did you meet some diabetic patients who have having joint problems and you would like to start your program with stress, and with the exercise to be stress? What type of stress, what type of exercises you advise them? They cannot walk, they cannot do severe. Did you meet some of your patients in your study?
Yeah, Dr. Abdul Karim, this is a very, very good question, and we hear it every day because as people age, they have back problem, they have knee problem, and so on. And in reality, strength exercise is one of the exercises that you can do even if you have a big problem. What is problem if you are asking people to do aerobic exercise? They cannot run, they cannot jog, they cannot do that much. But for people who have knee or back problem, the easiest way and simplest way is to do a stationary bike, recumbent bike. They lie on their back on the stationary bike. They put the bike against the resistance, so there is no body weight load on the knees. So they are recumbent, they sit, and they move their feet slowly against the resistance, which is very simple. And we found people with whatever level of knee problem, they were able to do it. They start slow and then they increase. A stretch band is another good way for people to do a strength exercise. And if they don't have problem with the shoulder, that can be also a very easy way. Very small weights they can do as well for biceps, quadriceps, and deltoid muscle. They can do some of this exercise. They can use a stretch band under their feet, and our exercise physiologist training them just to put the stretch band under your feet and push by your feet while you are sitting. The other and very simple way is that while you are sitting here, you can contract your muscle. Step on your toes, and then you contract your thigh muscle. So as you are sitting, you can still do a very good thigh muscle exercise. Strength exercise will be much easier when people stretch their muscles before they start strength exercise. And I encourage everyone when they wake up in the morning to just stretch all their muscles. When the muscle is stretched, it is easier to do some of those exercises. But knee problem, back problem is not an absolute contraindication for people to do strength exercise.
الأستاذ الدكتور أحمد المترف، تفضل.
Thank you very much for this very useful lecture. But the problem is when you try to convince 40 years old or maybe older man to practice either strength exercise or even walking in knee-free diseases, it's difficult to gain a hobby or habit at a later age. الحديث حق الرسول عليه أفضل الصلاة الذي قال استعينوا على كبركم بالمشي. كلمة على انه تبدا بالرياضه مبكرا وتخليها عادم معاك للعمر المتقدم. Our problem is the patient are reluctant to follow the instruction for our prescription to do exercise in case of either diabetes or heart disease or whatever. The core of the whole medication is the exercise. The problem is the patient are not follow our instruction. Thank you.
Thank you, Dr. Ahmed. The issue is we have to ask ourselves, is the inertia is from us or from them? Because if we have that concept that they will not be able to do, then this is our inertia that had been transferred to them. In reality, there is actually a big study among primary care physicians asking them, will your patients benefit from weight loss? They said yes. Will your patient get better? And then when they asked them, are you advise your patient to do a lifestyle intervention? They said no. And then they asked them why? They said, okay, people will not be able to do it. People will not lose weight. In reality, when it comes to real life, actually, when you tell people that you will get remission from diabetes, you have to do some exercise and make it very simple and doable. Exercise doesn't mean that people have to go to a gym to do exercise. If you stretch in the morning just for 10 minutes, just 10 minutes, and then you eat your lunch and walk in your place just for 10 minutes, and then in the evening in front of television have some little weights and do strengths for another 10 minutes. 10, 10, 10, 30 minutes. In 1 week, 210 minutes. It is more than the 175 minutes. You can easily do it. Salah. Salah is exercise. And actually it's a very, very good exercise. So it stretch, and it is also have some strengths when you squat and you stand up. At the beginning, I was skeptical that people will do that and look at very low calorie diet, but people fast Ramadan and they fast for 1 month, they fast for whatever. So, you know, if you have a goal, a very good goal, people will able to do it. I don't need us to transfer our inertia to our patients. Try with them and encourage them, and they will do very well. By the way, in Y-Weight program, 20% of our patients above age 70. I remember a guy did the program at age 87. Can you imagine 87 and did it, and more than 80 as well. زي ما بيقولوا في اللغة العربية الحركة بركة ومن تركها بركة.
الدكتور خالد القطاع أستاذ القلب كمان.
Thank you very much. Actually طبعا الموضوع الريميشن in the past was a dream. Now it's a real. What about the reverse of type 2 diabetic? It will be in the future. We hope so.
Will have a reverse of diabetes.
Yes.
It is advanced. You know, as long as there is beta cell function, you may able to reverse diabetes in a very nice way. In our practice now, it became like a tradition that we measure C-peptide for our patients to know exactly how much beta cell function, fasting C-peptide. And if the fasting C-peptide are within the normal range or exceeding the normal range, we know that those people can reverse diabetes. It is basically you put a motor suitable for the car. You cannot have a big car and a small motor. You know, if you have a small motor, then you need a small car. But reversal of diabetes is a very, very good concept. And in my personal opinion, I had been saying that for years, that we can reverse diabetes. Because if you understand the cycle, let me take a few minutes, if your time will allow, to explain the cycle. People don't inherit diabetes. They inherit certain genes that put them in a status of resistance, but only under one condition, when insulin goes up. So by age 20, 30, people start to gain some weight because the metabolism starts to shift. Energy expenditure becomes less, brain cut it down, and energy storage is higher. So they gain like few pounds. But you'll be surprised, 1 to 2 kilograms for someone with family history of diabetes, we're able to keep them in a cycle until they develop diabetes. Let me explain it in a very simple way. When they gain weight, they have more tissues. More tissues need more glucose. Pancreas start to secrete more insulin. But remember, genes are saying if the insulin goes up, the body will resist insulin. So now there is insulin resistance. So what the pancreas will do, keep secreting even more insulin to overcome resistance. But do you know that the problem is not here? The problem is insulin itself is a growth hormone. Make that person gain even more weight. More weight, more tissue, more glucose, more insulin, more resistance, more insulin, more weight gain, and the cycle keep going on and on and on and on. Until the pancreas will say, sorry, I cannot secrete more. And this is hyperglycemia, and this was type 2 diabetes. Insulin itself is a salt and water retaining hormone, raise blood pressure up. Dyslipidemia occurs. And then they will end up in your hand with heart attack or... so what we proposed 25 years ago, that if people from the beginning lose some weight, now less glucose, less insulin, they become insulin sensitive again, they become like hybrid car, they continue to lose weight because they don't have that much insulin. So you can reverse the cycle in the opposite way. But what we used to do is exactly the opposite. The patient come in and say, oh, your blood sugar is high. Let me give sulfonylurea. Stimulate your pancreas to secrete even more insulin. Terrible idea. They see more insulin, more weight gain, more resistance, and the cycle keep going on. They give up. They go to another doctor, say, okay, you know, the medication is not working. Let me give you insulin. You have endogenous insulin, you have exogenous insulin, you continue to gain weight, and the cycle keep also going in the same direction. So the best way people can do is to reverse the cycle early enough when you are still making a very good amount of insulin. And we found that 7% weight loss improved insulin sensitivity by 57%. So, to answer your question in a very short yes, diabetes can reverse it, and especially in the very early stage. And the chances for reversal becomes less and less as people advance in diabetes or use wrong medication.
Thank you very much. Thank you.
شكرا كثيرا دكتور أسامة. بس في طلب، يعني هل الريميشن بروجرام published، وهل كان can we translate it in Arabic to distribute to our patient?
We have a new publication called Diabetes Remission. I will send you the link for the article, or I send you the PDF, and you can distribute it to all your colleagues. And the program is available. We can send it to everyone. There is abstract that had been presented in the American Diabetes Association a couple of years ago. I can send you the PDF file of this. It's so simple. People can start doing it from tomorrow. I would like to see the results. And we are building a center now in Egypt. And one of the programs that we will do is diabetes remission outcome program in the plus the artificial pancreas and many others. So we hope that you will all be able to visit us in the future in Cairo.
Thank you very much. ونتمنى أن نكون على لقاء دائم، وشكرا للمحاضرة القيمة ووقتك الثمين، وباسم الجمعية اليمنية وكل أعضائها وكل الزملاء نشكرك كثيرا على مشاركتك السنوية. شكرا كثيرا.
أنا اللي سعيد بكم ومتشكرين جدا، وإن شاء الله نكون عندكم في اليمن الحبيب إن شاء الله في المستقبل.
Thank you لكل الزملاء، واعذرونا يعني الآن إلى الغداء. ملاحظة، يعني كل المحاضرات يعني ستنشر في الويب سايت حق الجمعية، وستكون موجودة في أي وقت تتابعوها، وبالويب سايت حق اليمنية المصرية. وشكرا لكم.
Diabetes is one of the most common health conditions worldwide, and type 2 diabetes is by far the most widespread.